Hello friends, I'm Dr. Ghoda. I'm Senior Consultant Gastroenterologist and welcome to my case diaries. Today I'm going to take a very prototype case. A lady who came with sudden chest pain and subsequently developed left effusion. Now, over years, I have learned that although sophisticated investigations have proliferated, good history will almost always, you can give percentage, say 90%, 95%, but most of the time, good history gives you the diagnosis, and if it doesn't give you the diagnosis, it gives an important clue that you have to investigate in this direction. So this is a very prototype case. I'd seen it in my younger days, but still good history taking is very useful as seen in this case. A lady came with sudden chest pain and breathlessness. She was 73-year-old. In the past, she never had this type of pain, but she did say that she had acidity for which she took some proprietary drugs, and it was well controlled. The day before this happened, she had heavy meals. Early morning, next day, she had severe retching and she vomited 2 or 3 times, bringing down the food, and all of a sudden she developed chest pain. She was rushed to the physician who examined her and found that the vitals were stable except for mild tachycardia and SpO2 of some 94. But he was not terribly worried. A cardiogram showed some STT changes, and she was suspected to have myocardial infarction because of chest pain and some breathlessness, and she was admitted into ICU. In view of her acidity and all, a gastro was invited to see her, and he suggested that we should do endoscopy, but this was denied, that we let her settle down. Importantly, her enzymes were normal. Cardiac enzymes were normal. Now, this is our very well complaint that cardiologist takes precedence over gastroenterologist in any setup, because cardiac things are supposed to be very life-threatening, aggressive, and sometimes they are. But so are some other conditions also. But anyway, she was seen admitted in the cardiologist and was being followed up. There was no improvement, and she developed some hypotension, tachycardia, tachypnea, SpO2 went down. So she had chest X-ray at that point, and it showed left pleural effusion. Now a chest physician was consulted, who came and examined her and found that she had some surgical emphysema in the neck. So cardiothoracic consultant was involved and he made a diagnosis. Now, can we make a diagnosis? There was some left pleural effusion also, sudden pain after retching, breathlessness, not improving, cardiac enzymes normal. So, a diagnosis can be made with this history only, that this patient must have esophageal tear, which we call Bornhouse syndrome. Any violent retching, against closed glottic especially, if you're trying to rush to the toilet when you feel like vomiting, and if you are holding back, or otherwise also any violent retching will produce through and through tear, which we call Bornhouse tear, and those who have, up to some people, we call it Mallory-Weiss tear. So this lady, if she had good history taken, probably she would have had the diagnosis on day 1. Even X-ray chest would have revealed either pneumomediastinum or air in the neck or air in the peritoneum, because if you get abdominal part of esophageal wall tear, then you will get free air in the peritoneum. So retroperitoneal air may be seen, a free intraperitoneal air may be seen like this. So this is very important. Bornhouse syndrome is rupture of esophagus. Transvenous rupture of esophagus is called Borehouse syndrome. For that, good history, CT scan these days would tell you, with good history and CT scan, you can easily say that this is esophageal tear. Obviously, it's very easy nowadays, but if you don't suspect such things, then probably you will not go for CT scan or even chest section sometimes, as it happened in this case. Left pleural effusion. Now, esophagus can start with lower end, can be in abdomen, so if it is ruptured, you will get free intrapleural air. If the lower part of the esophagus, thoracic esophagus, is in the left thorax, so if it is turned on, you will get left-sided pleural effusion. Sometimes you get tear in the mid esophagus, which is on the right side, so you may get right pleural effusion also. If cervical esophagus is ruptured, you will get air in the neck or X-ray. You can feel it as well, or you may see cervical air around cervical spine and everything. So you can, with good X-ray or CT scan, you can pinpoint or you can surmise or locate the lesion, that this lesion will be somewhere here. Now, Borehouse care is an emergency and it has to be treated very vigorously. Okay, so diagnosis can be made by CT scan very easily. Cardiac ECG and cardiac exams are always normal. There will be a history of sudden tear. Very easy. Nowadays, when you suspect this, the treatment sometimes is endoscopy. You carefully using CO2 so that there is no inflation, the air is absorbed very quickly. You have a look, and if you find a tear, then there are bigger clips available which you can apply and drain the mediastinum by ICD, so that whatever spillage is taken in the place in the mediastinum and in the pleural cavity is taken care of. Give antibiotics and your treatment is done. Where this is not possible, you must consult cardiothoracic surgeon immediately and plan accordingly. So, dear friends, very simple, straightforward case which was missed for a couple of days because of improper history and subsequent kind of treatment which was totally off the course in this case. So remember, investigations can tell you up to certain things. You don't treat report, you treat the patient, get good history, and patient is telling you the diagnosis from word go. Only thing is you have to let them speak and you listen carefully. Thank you very much.